postoperative pain. Now, if beta blockers decrease pain, decrease opioid consumption, does it really need to be treated with opioids intraoperative? Then I'm going to move to opioids and hyperalgesia in acute pain. And finally, perioperative opioids use and chronic pain, postoperative complication, readmissions, and finally, long-term outcomes. So it was very fascinating to me that when you look at the general considerations of opioids, early on, it was clearly identified that it was seductive, that it was something about opioid. Now, also, it was identified that there was a devil associated with. So over the years, I think we moved the bar and the devil was forgotten. So if you look at in this book called Narcotics and Anesthesia, published in 1984, it shows the anesthetist, he says, if I had to predict the future of narcotic and anesthesia, basically says, we haven't started yet. Narcotics are now considered an existing subject for investigation or an appropriate area of innovation and utilization. I certainly will predict that a dramatic development and increase in utilization will come in the subsequent years. And I think we saw this when cardiovascular anesthesia was done with high opioid dose, how we moved that bar. Of course, we didn't know at the time the crisis that we have today, so it was hard to predict where we will end up. Now, I'm not going to talk about the receptors. I'm not going to talk about the general concept, but clearly the opioids work in different places, brainstem, ventricle, and so on and so forth. Now, supraspinal anesthesia is where I'm going to focus for my first point because that's going to tell us or challenge the concept of intraoperative pain. Now, several opioids we utilize in the surgical setting, and finally, tolerance and hyperalgesia has been described in naive patients. So, at the end of the day, our indisputable benefit of the continued use of opioids that improve analgesia, improve the treatment of acute pain, and with that, decrease chronic pain. However, more data start to appear showing the neuroadaptation occur interferes with this opioid ability to provide long-term analgesia. Now, I love this slide that took from Ray Sinatra, where it shows that when we treat with opioids pain, sometimes all we do is we jump from one fire to another. We know they produce a powerful analgesia. We know that we have multiple agents, but at the end of the day, there are many adverse effects. I put a question mark next to safety profile. One of my last slides is going to show how many trials the FDA required in the last 20 years for an opioid to be deemed safe. And you're going to be quite surprised to see how little it was needed. Again, we know about sedation, nausea, vomiting, constipation, and so on and so forth. I'm not going to go over this. We know this well. I'm going to try to go beyond that. Now, Marvin has this incredible model for POCD, postoperative cognitive decline, where we look at interleukin sin, and there are interconnections between this model and pain. Marvin always told me that, probably the lion got hurt, and this message, the inflammatory measure will be probably today is a good day to stay in the cave. Probably today you have pain. It's not a good idea for you to go to hunt. And I'm going to come back to this concept because we're going to see how this inflammatory path have crossed in between these different situations. So my first question is, does intraoperative pain exist under general anesthesia? And again, I'm not going to answer that. We have to agree that probably we are not going to know it. For sure, we are not going to know it at the end of this talk. And the second one is, if we do need intraoperative opioids to treat intraoperative. Now, if we look at this book, there is the Irish Journal of Medicine that was published in 1926. Clearly, it challenged this concept, talking about narcosis, analgesia, and relaxation, and talks about analgesia being ideal. So the term narcotic probably will point us on to the wrong way and make us to treat those patients in a different way. Emily Brown have these papers published in the New England Journal of Medicine in 2010. Talk about how anesthetic drugs produce this unconscious and work in the cerebral cortex. My association when it comes to pain is that clearly there is an activation in between the second somatic and insular region areas. And that perhaps if you take that cortex away, given opioids to that area, it may not get a benefit. So it may modify this nociceptive pathway, but perhaps not in the cortex. So clearly this modulatory network may be already taken by the general anesthetics, so perhaps adding an opioid to the situations may not be the right move. So second question is, do we really need intraoperative opioids? And trying to answer that question is to compare patients that were treated with intraoperative opioids or patients that were treated with postoperative opioid-free analgesia. Now, if we look at this study that was published by Rojas et al., it shows that when you compare, in this case for patients who get lumpectomies, the ERAS group who have an opioid-sparing analgesia to the group who received opioids showed the first pain control without opioids was effective, but more importantly is that pain control not only was similar, but also patients who received no opioids intraoperatively were discharged without an opioid prescription. And there's another, Huron has a program that is very similar, where it shows that if you decrease or eliminate, in this case, intraoperative opioids, your prescription is going to decrease. Now, when we look at the concept of preemptive analgesia, we know that C.J. Wolf in 2007 published this very important paper where we talk about plasticity and pain. And basically, I mean, we can argue about the name, we can argue about the phenomenon occurs, but I think it would, if we look at this two meta-analysis done by Moynish and by Ong, it shows that wound infiltration will have a positive effect, continued epidural anesthesia will have a positive effect, a non-steroidal will have a positive effect, but clearly opioids, I'm sorry, my red arrow is a little lower than it's supposed to be, it doesn't have an impact on it. So clearly pre or intraoperative opioids will not impact preemptive analgesia. Now, if we look at the beta blockers in postoperative pain, if we look at opioid consumption, and for instance, in this case, are 19, I think the other speakers have, somebody has an open mic. You guys can shut it off, it would really help me out. I'm sorry. If we look at the 19 randomized clinical trials, where there was utilized esmolol, and when you have a sympathetic change intraoperatively, it shows that opioid consumption in the post-care and the PACU unit was decreased. The 70% of the reduction in rescue medication, as well as having better, which I didn't expect it, but it had better post-operative pain scores. Now, If we look at intraoperative ESMO as an adjunctive to the perioperative opioid and postoperative pain reduction, if we look at the systematic review, this meta-analysis, we have 23 randomized clinical trials, very similar data. We can see very similar results. So intraoperative opioid consumption, one more time, decrease. Opioid consumption is decreased, and one more time, we have VAS scores that they are better in the patients who receive esmolol compared to the patients that receive opioids. Maybe the pathway is very similar in a way. So if you look at this paper, shows that dopamine and beta blocker modulate plasma IL-6. In this case, a patient with congestive heart failure, which is a very similar pathway. How we know the inflammatory component of acute pain occur. Now, what about opioids and hyperalgesia in acute pain? So first, when we talk about opioid-induced hyperalgesia in acute tolerance, there are very similar phenomena, right? So I think we know tolerance very well. Patients who take opioids need more opioids, but again, but this phenomena has been identified, and now more and more data suggest that, for instance, patients who have tolerance have more hyperalgesia. They have very similar basic substrate, and I put 3 references in there. 3 of our papers have shown that, and also, high dose opioids is associated with higher incidence of it. So I think the $1,000,000 question here is, if you decrease the dose up to a point, will this phenomenon disappear? The answer is I don't know. We know that remifentanil produced this phenomenon, but also all opioids do have a similar phenomenon. Probably if remifentanil was never invented, we will never know about hyperalgesia, but now we have data where we know that they are all produce some type of hyperalgesia. Higher dose, more, we see it more, but again, it may be that, we put this in our paper where we hypothesize that this lack of inhibitory effect or deficient inhibitory effect is what is going to increase this post-surgical pain. So, we put in our systematic review that, remifentanil, high dose of remifentanil produce more hyperalgesia earlier than long-acting opioids. The high intraoperative opioid dose increase postoperative pain and opioid consumption. And again, when you have tolerance and you have hyperalgesia, the opioids are not as effective as they would be otherwise. I showed you before the correlation with IL-6. Here we can see the inflammatory pathway, IL-1, TNF-alpha, and nitric oxide pathway. They're very, very similar with the data that I showed you before. Now, this paper is called Hyperalgesia with remifentanil, short-term gain, long-term pain. Again, shows very similar results. And again, a postulate a completely different pathway. And that's the reason that I put it. And again, one more time, the dose is much higher, 0.25 micrograms per minute. So for us to consider. Now, if we look at systematic review and meta-analysis on hyperalgesia and morphine consumption thereafter, we can see the high-dose remifentanil intraoperatively are associated with increased perception of pain, increased after surgery, and increased morphine consumption. And here, some of the numbers, unfortunately, we don't have time to go through. When we look at timing, when this effect occur, we know that the longer that you use it, the worse is it going to be. So patients who have tolerance, it has an enhanced post-surgical pain, increased opioid consumption, increased stay in the hospital, chronic pain, and use. Also, we can see that those patients have an early onset of what is called opioid-induced hyperalgesia. And this observation in all these 5 papers was seen not only with remifentanil, but also with fentanyl as well. When we talk about remifentanil associated with acute chronic postoperative pain after a prolonged surgery, we found 21 studies, and it shows that similar data: high acute postoperative pain, higher postoperative analgesic requirement, as well as remifentanil use. Now, the only thing that is very interesting is that most of those studies where hyperalgesia occur was done with volatile anesthesia. Very few studies with TIVA did not show the same results. So one of the questions in my mind is, this is a phenomenon that only exists when you use remifentanil with volatile anesthetic, or this is a phenomenon that occur across the board, and doesn't matter if you use TIVA or inhale. The thing that we know is that you can add remifentanil to TIVA, but at the end of the day, there is no much variability on the dose of the other drugs utilized in your TIVA recipe. So probably we can argue that the benefit is not. 6 more studies right here, one by our own friend Harold Minkowitz, to support this phenomena where chronic postoperative pain after prolonged surgery exists and is a real phenomenon. Now, the next step, moving after acute pain and hyperalgesia, is, does the utilization of perioperative opioids take you to chronic pain? Now, the theory behind this is that if you give it a high dose opioid, you will activate pain. And when you activate pain, I'm going to take a minute. Sorry, there were people outside my office just having a party. As you have a high dose of opioids, you have this activation of pain nociceptive mechanism. You get this hyperalgesic response, and this hyperalgesic response is going to produce more acute tissue injury, which is going to close the circle and take you to use more opioids. So here again, you have 2 pathways: an anti-nociceptive system that we know that occur and is beneficial, and then we have a pro-nociceptive system where this alteration, as you can see right here, they have a tie a pathway closer to the inflammatory pathway. For instance, IL-1 will be elevated. It will produce pain, hypersensitivity, hyperalgesia, and allodynia. It will take you to chronic pain. So again, there is no much human data. There's animal data. For instance, in this case, this paper published by Grace shows the morphine treatment after laparotomy, prolonged postoperative pain. Prolonged postoperative pain in these rats. A couple of observations. You can see the morphine in red in the figure on the left has a beneficial effect, but that beneficial effect is lost around 28 days. And when you look at the figure on the right, you can stop that abruptly, or you can taper, and it make no difference on what is going to happen. One more time, the conclusion: the study indicate that morphine can be deleterious, had a deleterious effect on postoperative pain, and suggest that perhaps we are treating fire with fires, that perhaps more studies should be done. Very similar result on a completely different pathway. This study by Grace Peter shows that morphine may prolong neuropathic pain in rats, amplified in NLRP3 inflammasome activation. So again, another pathway. As I say before, in chronic pain, we don't have much data. So these are initial steps trying to identify the phenomenon. Now, if we look at this study where we look at patients in between 18 and 65 years old who have a persistent use of opioid over 90 days, the conclusions were that 6% of the patients use opioids for more than 3 months. The persistent opioid use is no difference in between patients who have minor or major surgical and the patients who have prolonged opioid is not entirely due to surgical pain. So here I'm walking a really fine line. I'm trying to see if truly those patients take opioids because they need it, because they took too much opioids, or because they took opioids and they like opioids, now they're using opioids. So I can't say for sure. All I know is that if you use opioids early, you get more opioids. If you get more opioids, you are more frequently chronically being an opioids more than chronic pain. But again, since we don't have any human data, I just put a paper there to make it a little more palatable, so to speak. Does remifentanil is associated with acute or chronic postoperative pain? When you review the literature, what you're going to see here in these 4 studies and thoracotomy, cardiac surgery, I mean, this is the surgery that we know the patient have more chronic pain, sometimes up to 50%, suggested there is a potential association between the use of intraoperative use of remifentanil and an increased rate of chronic pain compared to patients that did not receive intraoperative remifentanil. Now, we talk about hyperalgesia, we talk about acute pain, we talk about chronic pain. What about postoperative complications? So if we look at this 7 million patients and we look at opioids and pulmonary complications, these patients, this study was published a couple years ago in anesthesia and analgesia. It shows that the composite outcome was increased. Also mechanical ventilation was more commonly used in patients who receive opioids. Reintubation was also more frequent. So it shows that additionally that those patients had a longer length of stay as well as greater cost. So maybe in this 7.5 million patients, there was an association in between perioperative use of opioids and pulmonary complications. How about delirium? I think there are some deliriums of ICU opioid use, not much in the perioperative stage. This is a study who shows that 40% of the patients who do have delirium, we know that. That's probably true for those patients that are over 65 years old. And what we see right here is that patients who have more pain, 72% compared to 20%, have more delirium. Again, I think we can argue that patients who have more pain have a worse inflammatory process, if we believe what Mervyn May said, and perhaps that's the reason why they're going to have delirium. The observation is that more opioids, more delirium in this case. Readmissions, we look at this registry from the New England Network, and it shows that it doesn't matter if you use short-acting opioid or long-acting opioids. The longer that you use it, the more the remission is going to increase. The curve on the right, I really like it, and every time that I have an opportunity to attack the surgeons, I do it, shows that the gray curve shows that the data is showing you who is going to need prescription and who doesn't. The red in the left shows the anesthetists follow that curve quite well. If you look at the surgeons, they didn't learn very much from what the partners show, and they do the same thing anyway. So maybe that those patients have more readmissions related to opioids because they got more opioids anyway. It doesn't matter if they need it or not. If we look at total knee and total hips, in this case, opioid-naive patient has a lower readmission day, the 30-day readmission day, as well as the 60-day readmission day was had a direct correlation with opioid use, as well as revision had an increased risk with 30-day readmission. And this is 324,000 patients, so it's very significant. Now, long-term outcomes, if we look at this paper, shows the higher opioid use predict poor functional outcome. In this case, is in chronic disabled patients with musculoskeletal disorders. So there are no surgical patients. So 1,200 patients, it shows the more opioids you use, they have a lower rate of return to work, lower work retention, higher care utilization, more Social Security disability, and more supplemental income was needed. If we look at this study where it shows the relationship between early opioid prescribing patterns in acute occupational lower back pain, disability, duration, cost, etc. Also, very similar study shows that patients who receive opioids have 69 days longer, as well as the risk of surgery was 3 times higher, and the risk of receiving the ones that received late opioid was 6 times higher. So basically, there is a negative association between receiving opioids and a lower back pain outcome, suggests that the use of opioids for the management of this disease should be counterproductive to recovery. If you look at the pain surveys, very similar results. Post-surgical pain exceed 50%. I think we know that data. Opioid use is higher in patients who have chronic post-surgical pain. The majority of those patients still using, and it's still using after 3 months. The chronic opioid users have a lower overall global health, as well pain-related disability in early life, working and mood. So there's a correlation between early opioid use and how they're going to do that. One more study here. It's a cross-sectional study, 1,500 patients, and again, show the same relation. The reason this study is important to me is because 60% of the opioid users remain chronic opioid users. So that always in the back of your mind is that question: are they using opioids because they were using it before? But when you look at naive patients in the study, it shows that 20% of the naive patients then start to behave identical to the chronic opioid users. So in my mind, I think this clarifies a little bit that those opioid naive patients that were never exposed, now out of the sudden, they have a similar behavior to the patients that were chronic opioid users. In this case, if we look at perioperative opioid and outcomes on arthroscopic rotator cuff repair, 79 patients, very small study. Now we can see that the non-opioid group had a significantly better postoperative patient-related outcome, as well as better external rotation measurement, which to me was a very interesting observation. Finally, let me touch very clear, I'm not an expert in this area by any means. My good friend Juan Cata is probably one of the leading expert in the world. And we know that opioids may have a relationship with cancer. So pain and immunity go hands to hand. High intraoperative opioid use has been associated with an increased recurrence in certain cancers. Opioids suppress, we know, the immune cells, such as the NK cells, and opioids modulate tumor microenvironment. Juan's data show here, not only in vitro, but also in vivo, that certain cancers like lung cancer, breast cancer, prostate cancer, ovarian cancer, GBMs, in those cases, there are all has been a relationship on tumor growth and inhibition in the inflammatory process when those patients are treated with opioids, and mostly with morphine in the case of cancer. Finally, safety and efficacy. One of the things that we always say is that we use opioids because they are safe. Well, let me tell you that perhaps in 1997, safety was defined differently than how we define safety today. This paper was published 3 or 4 days ago in the Annals of Internal Medicine, and basically shows that to get an NDA for safety and opioids, if you look at the second column, it's fascinating to see that most of the trial, many of these trials, have less than one pivotal trial. So wonder why, and now we have such a opioid crisis, and we have too many problems. I'm not going to expand on this. We know that more than 5,000 people can die for this. It's probably one of the worst epidemics that we have seen here in America. Even we can even found most of us in the coast of Seattle who test positive for opioid due to this problem. Um, just to stay on my time, thank you very much. Sorry for rushing through all this data. I think we're going to get some questions. Thank you very much.
Thank you very much, Sergio. I just take the word in order to give time to Professor Irene to open her presentation. It was an excellent presentation about the opioids and discovering the phase that opioids has. It's true that a lot of us thinks that opioids are safe and we more than need them. But obviously, there are other alternatives. If we think about that concept that Dr. Gray already explained in 1962, saying that pain doesn't exist, so we shouldn't talk about analgesia during anesthesia, but reflex depression. So I think that Professor Osborne is already ready.
Yes, I'm hopefully going to. I'm not screen sharing. Sorry. What did I do here? Maybe you can make my slides come up. Do I?
Yes, I think I can do that for you.
Okay, good, great.
Oh, it's
terrific.
There. Great.
Thank you very
Excellent.
much. Okay.
The word is yours.
Good. Good evening, everyone. I am going to shift gears a little bit in this discussion, and I'm going to talk about HFVI. What are we measuring? Now, hold on a second. First of all, there are a lot of acronyms involved in understanding this technology, and HVFI is actually is high frequency variability index. So let's not get confused. I'll start by disclosing that I am a clinician. I have received and purchased equipment and for clinical use and assessment from M. Dolores. I became very curious about this a year and a half ago. I heard a presentation about nociception monitoring, and I really wanted to explore it. Like Dr. Borges, I'm a neuroanesthesiologist, but I found myself really struggling to manage patients for spine surgery. And given the fact that I've been doing this for over 30-something years, there's always something new to learn. I work in a training program, and I'm very fortunate that my program was able to get this equipment for me because I thought it was extremely exciting. So I'm going to talk about the theory of nociception monitoring and what is HFVI, high frequency variability index, and applications to clinical anesthesia. And as I said, I'm not an engineer, but I do like monitors and I care a lot about my patients. So as we heard before, pain is really the human experience. You have to be conscious to experience, to talk about pain. We have scales that tell us how bad our pain is when we're awake. And of course, there's a specialty in anesthesia that's devoted to chronic pain as well as acute pain. But what we want to focus on is nociception. And nociception is the body's response. It is the transmission of unpleasantness from the periphery to the central nervous system. Now, giving anesthesia in the modern world, we have many tools at our disposal. Of course, as a neuroanesthesiologist, I love being able to monitor consciousness. So we feel very comfortable now with our processed EEG, knowing that we can monitor depths of sedation, depths of hypnosis. Our surgeons are very happy now that we can provide immobility. We can provide immobility and monitor it with nerve stimulators, and we can now reverse it. How wonderful. At the same time, analgesia is the component that is very much a toss-up. We base our dosing and our understanding of intraoperative analgesia based on the patient's hemodynamics response. And then on top of that, there is the cardiovascular control and protection that we also have to manage, some of which is related to the surgical experience and some of it is not. So in trying to, I want to focus on that nociception idea. So yes, these are signs of pain and stress that can, of course, happen under anesthesia. We know them all if we work in the operating room. Tachycardia, hypertension. If you're looking very carefully, you can see pupillary dilation and, of course, diaphoresis and salivation. Once again, very, very simple clinical responses. So the clinical signs, of course, would include patients moving, patients sweating, patients having hemodynamic response that would appear to indicate that there is some stress going on. In trying to quantitate what's going on, we look for reflex pathways, and these have been described. Researchers have looked at skin vasomotor reflexes, and there's a body of literature looking at a plethysmography as well as heart rate variability. But we're going to focus on heart rate variability because that seems to be the sign or the technique that we can use to help us understand nociception. Now, as I said before, there are other modalities that have been used, and if you look here, you'll see the analgesia nociceptive index, which is what we're going to talk about. You can look at bispectral index as a possible measure of nociception, but only if that's profoundly stimulating and it's not very sensitive at all. The patient is asleep, a lot of stress is happening, and it's not terribly sensitive. Pupillary diameter, interesting, not always practical to do in the operating room. Surgical pleth index, I have not had any experience using. Of course, heart rate and blood pressure are what we use in the operating room and what we depend on. So we're going to focus primarily on heart rate variability as a measure. Now, in 2010, this was one of the early studies just looking at the fact that there was a noxious stimulation response index, looking at this hypnotic and opioid interaction in patients. And there was an interaction. There was the ability to see an index of stimulation. And from there, we've gone to a little more sophisticated technology. Now, the heart rate variability is based on the physiologic principle that there is respiratory sinus arrhythmia. So when I take a deep breath in, my heart rate increases. When I breathe out, my heart rate decreases. And everyone has this physiologic ability that happens. Of course, it varies in a number. So in the parasympathetic reflex loop, as I mentioned before, we have an increase in heart rate with inspiration and a decrease with expiration. One of the reasons when you go to yoga class, you're able to relax yourself with breathing. And this is during the conscious phase of our lives. So heart rate variability is an extremely exciting technology. It's used by athletes. It's used by a number of people who want to monitor their conditioning. What they're looking at is the robustness of the autonomic nervous system in trying to control the body. particularly the parasympathetic portion. Now, we haven't gone into a lot of basic stuff, but your sympathetic nervous system is the sympathetic versus parasympathetic. And when you're giving a lecture on Zoom, your sympathetic system is kind of rises like this, and your parasympathetic is trying to keep you calm. So we have this dynamic back and forth in our lives, but under anesthesia, we try to control it. And I think getting control of the autonomic nervous system is an important goal. We do it in various ways. We've done it with, as Dr. Borghese mentioned, we've done it with opioids because we think it's a good idea to control the stress that way. But as we'll see, and as we know, there are certain consequences for doing that. Don't want to get off topic. So in trying to determine and find this index, the analgesia nociceptive index, or ANI, looks at the heart rate variability, looks at the RR, which is measured at the bottom of the screen. So we're looking at the heart rates between respirations, and we're utilizing heart rate variability as well as respiratory sinus arrhythmia. These two things together are going to help us to generate this index. And so the lead placement is fairly simple. This was one of the advantages of using this monitor, was it did not require a lot of fancy in-service. You put it on and you basically get a vector across the heart. So we have to get a good RR EKG in order to generate the information that's needed. Yes, it can be done in the prone position, and you can place it on at any time during the surgical procedure. So what's happening is we're utilizing this reflex loop. We're looking at the RR intervals, and what we're trying to find is the variability between these RR intervals. This is the important part of the response. And I'm going to have to read this because it reflects the parasympathetic modulation of the heart. And this is measured by filtering the beat-to-beat series in the high frequency domain. That's where the high frequency part comes from. So as nociception increases, i.e. more pain, more stress, the parasympathetic tone decreases in response to increasing sympathetic activity. It's one or the other. And this then leads to a decrease in the index. Now, the index is generated. So we look at this heart rate response. We then run it through a important wavelet transformer, and we find the high frequency waves. We look at the area under the curve to determine what is the degree of parasympathetic activity. And we then, it's actually the high frequencies which express parasympathetic tone. The lower frequencies represent sympathetic tone. So when we've done this, they generate a scale between 0 and 100 to give you an index of the parasympathetic tone. Now the index is calculated over 1 minute. This gives you a faster faster representation, and also at 2 minutes, which gives you a slower trend to see where things are going. So once again, we're filtering our RR series, and then we're going to look graphically at this area, which is looking at the gross representation. And this is as I said, the 60 seconds for the fast generated waveform, and then the other one, which I'll show you in a moment, is a slower generated waveform. So, and there's one mistake here which I made. This is from an article that I wrote with some of my colleagues describing the monitor. So when you look at it, what you see here is what's called the nociception balance. This is the slower number. The yellow number, and I'm sure Dr. Moon will describe this as well, is the more rapidly computated number. The energy actually represents the potency of the parasympathetic nervous system. So this is not really correct. This is our ECG. Is our ECG on the bottom, which is showing us our heart rate as it happens in real time. And this is what is generated over time. So the quality of the signal, of course, can be affected by the placement of the sensor, of course, any other factors that are going to affect the recording can potentially affect the quality. But because it is averaged so carefully, I find this to be incredibly robust in my experience so far. Now, I'm not going to cover a lot of studies. If you can see there is an interesting and exciting body of research that has been done on heart rate variability and also nociception. But I think what was interesting was to see the study by Sandra Funk, where she compared different modalities to validate this, and she actually was able to look at she was applying tetanic stimulation and looking at the responses of different modalities. And so what she was able to show was that something we saw, of course, in our own clinical experience is that bispectral index is neither sensitive to painful stimulation. It doesn't really give you a good marker of analgesia. However, she did find that of the modalities that she studied was that the ANI value was most sensitive to demonstrating what was happening and was very interesting. In terms of what you do see with it is that it can predict the response. So when you see the changes that are happening, this may happen before there is a hemodynamic response, which is what's very interesting and exciting by this. So you can anticipate when a patient is going to have heart rate, tachycardia, hypertension, etc. And in looking at her study, once again, there was a very rapid and reliable response from the ANI compared to other modalities. Now, my observations were pretty straightforward, things I expected to see as I work in a training program. And of course, when there is a laryngoscopy that takes a little longer than you expected, you see the responses, you see the change in the ANI. Of course, there might be some heart rate, some tachycardia, hypertension, but you see this happening almost in real time. And then, remarkably, this is another case, just an example, when nothing is happening and the patient is under general anesthesia, there is a rise in the value, basically indicating that there is no stress. The patient is completely analgesic until the next moment of stimulation comes along. So those were some interesting early observations that we had. In one of the studies that I thought was important because it pertained to my group of patients was by Upton, and they looked at intraoperatively using the ANI guided fentanyl administration versus standard care. And what they were able to see was in this particular study, they actually used less opioid intraoperatively, and that the patients had lower pain scores postoperatively compared to controls. Now, this was one study. This has not been consistent. There were some studies that did not show a predictability for postoperative pain, but it was certainly important to see that, yes, pain is going to be variable intraoperatively, and your decision as to what to give, opioids or other agents, can really be determined by using this monitor. So intraoperatively, as you can see, the surgery is going on. You're watching what the surgeon is doing. You're also watching the hemodynamic monitors, but it's fascinating to see how it mirrors what's going on, and things that you think are going to be painful are sometimes not. And so you find yourself, as you're using it, getting a little more comfortable interpreting what's important. So the ANI scale And I made this very quickly based on some really some cases of mine. 100 to 70. If you saw someone with the in that scale, you might decrease opioids. In other words, if they're in the high ranges, they don't need any more opioid. In fact, if you continue going in that range, your patients may actually overdose. I had one or two people who woke up and they were extremely comfortable and almost required naloxone. So the ideal range is between 50 and 70. So you want to have that range, which demonstrates that your patient is not experiencing profound stress. You can see what happens when different agents are given if there's a break in the surgical procedure. Now, what's more interesting is that when the scale is below 50, that's the patient that usually is very uncomfortable, and probably you want to increase analgesics of some type. And I say of some type because I think there's potential for using this device to guide multimodal analgesia as well as titrate opioids. This was another case. I do craniotomies. I put it on patients during craniotomy, and yes, it confirmed what we see in craniotomies, which is like we know there are no pain receptors inside the brain, but when they start to close or do other noxious stimuli, there's a response. So our patient was in the frame, and then we performed a scalp block, and there was no response. The patient was not aware or feeling the discomfort of being in pins or having any of the response to that. And that was exciting, particularly if you're using drugs such as remifentanil. Now, remifentanil is great to use, but we know there's a downside, as Dr. Borghese has told us. And we might have the ability to I think, appropriately titrate how to use remifentanil. In other words, maybe using lower doses is probably better in the intraoperative period if you're looking at hemodynamics as well as HVFI. So today's our patients that I anesthetize, they can be extremely challenging. Morbidly obese, older and sicker, and chronic pain. And sometimes you have the patient with all three. And so how do you treat them? How do you manage their surgical experience? I really think that we as clinicians could certainly do better. Just as a simple example, this is a patient with chronic pain for spine surgery. And yes, we perform TIVA, propofol, and remifentanil. It's easier to do. We're using somatosensory potential monitoring. What we saw was that every time they stimulated the somatosensory potential, we had a response in the HVFI. And so this told us that the patient was experiencing this, but hemodynamically nothing was happening. So we did decide to give the patient, in addition, some methadone, ketamine, dexmedetomidine, and she was extremely comfortable on emergence. Just one case, but I think we certainly have to look at this and see what are the advantages. So why do this? Individual titration of patients, I think, is extremely important. Everyone's response is going to be different. If you're going to do nerve blocks or you're interested in trying to provide preemptive analgesia, this is a great idea. Increased or incidence of over and under dosage, and of course, potential outcome improvement. That's what we all really, really want. Limitations, yes, there are some limitations. If the patient's having arrhythmias, we're not going to be able to get a reliable heart rate variability index. If the patient's apneic, we're not going to be able to see this response between respirations, obviously. Electrocautery for a short period of time, agents, anticholinergic agents that are going to increase the heart rate are certainly going to affect the responses and of course the reliability. And of course, vasopressors haven't had a lot of experience, but I don't think it's going to make things as reliable as we would like. So and I took this from the M. Dolores website, HVFI calculation. The first step is calculating relies on the RR time intervals. putting the intervals, filtering them in real time, looking at this detection algorithm, and looking at extraction of the ECG, embedding into their algorithm, and looking at this display in the indices. After you use the monitor for a while, you're not focused on the number so much as you're looking at the energy. You're looking at the area under the curve, and that is important. If it's the same as if you're using SedLine or EEG monitoring. After a while, or BIS, you don't care about the number. You're looking at the raw EEG, and that tells you quite a bit. So this was also interesting, and this was one of the first American study looking at high frequency heart rate variability. This was a prospective observational trial assessing the utility as a marker between analgesia and nociception, and this is really what the crux of what they are. Are we giving enough analgesia intraoperatively, and can we do it otherwise? And so they did a number of patients, and they observed the hemodynamic response. They also looked at the reflection of the HFVI with stimulation such as direct laryngoscopy, OG tube placement, obviously abdominal insufflation. They give hydromorphone. There's certainly less reactivity, of course, and it was interesting and as I said, an observation, a validation that looking at this might be able to give us some indication as to how to go forward. We also know from data after another study that there's a strong correlation with classical heart rate variability analysis and as related to the percent of parasympathetic activity. Stress is the well-known enemy in modern life, and I think it's important that we don't pass on this stress to our patients. A number of us in the United States are, of course, experiencing a lot of stress. Some of it is happening later tonight, and so we really want to try to get control of our own autonomic nervous systems as well as our patients. I think we have the potential to anticipate hemodynamic activity to protect our patients from unwanted tachycardia or harmful hemodynamic activity. I think we can certainly anticipate postoperative pain and perhaps manage it better prior to the patient awakening. And we might be able to diagnose the etiology of hemodynamic events. In other words, as we heard in the first lecture, maybe we don't have to give opioids. Maybe we can use other drugs such as beta blockers to control hemodynamic activity. And of course, titrate opioids appropriately. Certainly more studies are needed to understand this technology. And I want to thank Nacho Gonzalez and M. Dolores for giving me the opportunity to understand this. Thank you.
Thank you very much, Dr. Osborne. An excellent lecture again. It was a pleasure to hear from you how the HFVI is obtained, which is basically what the acronym says. It's high frequency variability index, which is linked obviously to the autonomic nervous system, which at the end is what we need to take control, right? Is what it is important at the end of the day in order to improve the outcomes of the patient. So now we're going to give the word to Professor Moon from Texas University. She's going to give us as well her experience about the use of HFVI in the OR. So thank you. Tiffany, you have the word.
Okay, can you guys see the slides? Yes?
Yes, it
Okay.
goes perfectly well.
So this is my experience with the HFVI intraoperatively. I'm going to share with you some cases that I've done. So first, we're just going to talk about some of the logistics. Dr. Osborne already went through a little bit of this. We'll talk about how I use the machine intraoperatively and then some clinical cases that I've done. So again, there are some people for which ANI should not be used, those not in normal sinus rhythm, those with irregular respiratory pattern, or those who are apneic, and then patients who have implanted pacemakers or have had a heart transplant. So like Dr. Osborne mentioned, the monitor is very easy to use. It comes with a clamp that goes onto your IV pole, and all you really have to do is place a sticker on the patient's chest, rather 2 stickers. The rectangular one goes just below the clavicle on the right side of the chest, and then the round one is about V5. And like she said, the patient can be prone. The only time I've ever had a problem with this setup is when the patient was having a sternotomy and my sticker was in the surgical field. I was unable to do that case, but in 99% of cases we have no problems putting the stickers on the chest. And then just a tip for you, for those of you who have patients that have a lot of hair on their chests, you don't have to necessarily shave it, but it helps to add a little bit of lubricating jelly and then place some tape over the electrode. And that will help maintain the signal, especially in cases like robotic cases, where after the robot is docked, it's going to be very difficult for you to reach under there and mess with the leads. So right when you turn your machine on, it will go through a period of initialization. So I tend to plug it in fairly early while I'm putting in my other monitors, because this can take a minute or two. And then you want to make sure that the quality signal is good. I don't start the case until I get a good quality signal, because I really like to see the beginning of the case, sort of what the patient's baseline analgesic state is and how they respond to the induction of general anesthesia and intubation. So I want to wait until I get a really good signal before I start the case. And then the machine is plugged into the wall, so it has electricity. But if it inadvertently becomes unplugged, it does have some battery life, and each one of these bars will last you about 10 minutes. So if you start noticing that they're getting low, you have to plug it in. And then last but not least, if you plan on extracting data from the ANI monitor, which you can do, it spits out a very nice spreadsheet of all the numbers. If you plan on correlating that with hemodynamics or medications given or patient pain scores, any sort of research, you must make sure that the time on your monitor matches the time on your electronic medical record. And I say this because I really learned that the hard way. I had to manually fix a bunch of times. So here we go. So now we have a good signal. We're getting started. The number in orange, as Dr. Osborne mentioned, is the mean HFVI number. And I think it is averaged over about 120 seconds or so. And then this yellow number is instantaneous. So it moves faster. So if you look to your left on the chart, you will see that the yellow line is a more volatile line, if you will, than the orange line, which is basically a smoothed out version of the yellow line. So for example, in this case, right when we put the monitor on the patient, they had a baseline ANI number of about 70 or so. We gave them 100 micrograms of fentanyl to premedicate, and then proceeded with induction. You see that there's a little dip right there, sort of with the, I guess you would think that being induced is a little bit frightening or noxious for the patient. And then you see a very large jump up, almost to 100. And that, I think, is very telling for patients who are very opioid sensitive and also have a high parasympathetic tone, because you've just induced general anesthesia. And then, of course, you see this rapid dip because I happened to be working with a medical student that day, and the laryngoscopy was probably a little bit more prolonged than it would have been otherwise. So that kind of, the ANI is very nice in this way because it sort of tells a story. On the bottom, you'll see the timestamp, and each rectangle is about 5 minutes, which is pretty good because I usually tell my residents to watch the numbers, and if it's still in that same range in 5 minutes, then we make an action. What I like to teach my residents is that the HFVI is not like the pulse ox. If your pulse ox goes from 99 to 92, that's very alarming, and you should do something very quickly. If your HFVI goes from 52 to 33 over 5 minutes, it's not of the same sort of alarming value as a pulse ox. You can sort of let things ride for about 5 or 10 minutes before you act on the numbers. So this is a case of a patient who was involved in a MVC, multiple injuries, splenic laceration, liver laceration, multiple broken bones, things like that. This was after he had been in the ICU for about 3 days and coming back to the OR because his abdomen had been left open with a Abthera device and they were washing things out. And during the case, he was tachycardic and hypertensive. And he had a lot of medical issues going on. He had been intubated for the last 3 days. He was a multiple trauma patient, and he had been on a fentanyl drip in the ICU for the last 3 days. So certainly he had some acute opioid tolerance. So the question then is, are these hemodynamics that we're seeing right now due to inadequate analgesia? So we look to our ANI, and this wasn't this exact case, but we'll pretend that it is. These numbers, 73 and 80, illustrate that the patient at this moment seems to be at a good level of analgesia. And you can see that about 5 minutes ago or so that fentanyl was injected, and then the yellow line tends to be a bit volatile. So sometimes it's nicer to track the orange one. And you see this nice peak onset of fentanyl, 5 minutes later. So it's very nice. There are circumstances. So in this patient with the current hemodynamics, I would say that it is unlikely that his hypertension and tachycardia at this time are due to inadequate analgesia. There may be a problem with his ICP. He may be getting SIRS symptomatology on moving the patient from the ICU to the OR table. The resident may have dropped the A-line transducer, and all of a sudden it's on the floor and everyone thinks the pressure is high, and it's really not. You just pick up the transducer. So I think it's something else. But at this time, I did not think that it was appropriate to give additional opioid or other analgesics. Okay, now let's pretend that this is the exact same case, but when you look at the HFVI number, instead of 80 and 73, you now have 43 and 20. So this is telling a completely different story. I had to make up this one, so the graph doesn't match. But let's just use the numbers and say, well, the 20, that means instantaneously it's dropping. The patient is experiencing some sympathetic stimulation. And then the orange is just following behind that. In this case, I would say that the current hemodynamics with the tachycardia and the hypotension may very well be due to inadequate analgesia. And I would try to increase the patient's analgesia and then see what happens with the HFVI. So it's just another tool to tell you in your assessment of the clinical picture what's happening with your patient. So now we'll take a different case where the patient is hypotensive. Pain control and inflammatory cascades and all those wonderful things that Dr. Borghese was talking about chronic pain and all of those things. Well, that's probably not on the front of your mind when your monitor looks like this. Right now, you're thinking, oh, what just happened across the field? Are we bleeding? Is something going on? Can we resuscitate? So after the patient is adequately resuscitated, it's important to then go back to the ANI, because it's not mutually exclusive that the patient can be under resuscitated, but also experiencing inadequate analgesia and the inflammatory cascade that Dr. Varghese explained. So they're not mutually, you have to remember that just because their blood pressure is low doesn't necessarily mean that they're not also in pain. So I wanted to highlight this part on the ANI for those of you who are going to use it, because it's a very user-friendly device. I would say that within the first 3 to 5 cases that you use it on real patients, you understand the machine, you understand what the numbers mean and how to interpret it and how it's sort of predicting what analgesic state the patient is going to be in. But in any case, there are these parameters on the lower right-hand corner. And sometimes during periods of hypotension, like I showed you in the previous slide, the ANI may be low. So here, the ANI looks like it was about 40 or so for a few minutes. Because a lot of the cases that I participate in are research cases and we have to follow a protocol, it says that if the ANI drops below 50 for more than 5 minutes, give X, Y, and Z. So we mark when we don't give X, Y, and Z, basically when we deviate from that protocol, because the patient was hypotensive at the time and I'm doing other things, I'm not going to give additional analgesics at this time. So the monitor is very user-friendly and very helpful for marking when things happen, and then you can export the data and match it with the data from your EMR, which is a very, very large spreadsheet that you then hand to a statistician, hopefully. So the last case that I want to discuss with you is a 56-year-old woman who came in for an open abdominal hysterectomy. She looked pregnant, but in fact was not. She had a very large uterine fibroid. She had a history of diabetes, mild hypertension, was an occasional smoker. And in our preoperative area, as part of our ERAS protocol, the patient was given 600 milligrams of gabapentin and 1 gram of acetaminophen PO, and then brought into the OR and underwent a very standard induction that we commonly do with the drugs that you can see here. And it took them about 3 hours to get this very large fibroid out of her. And I think the ANI did not go below 50 very much. I will show you this picture here. So this is not from that exact patient, but it's representative of that case. I think maybe 2 times for within a 5 minute period, and you have to remember each of these rectangles is only 5 minutes, she dipped below 50, but that was it. So for the rest of a 3-hour case that was an open hysterectomy, she was what we call riding high. She was in the ANIs of 60s, 70s, 80s. And the few times that she dipped below 50 when they were sort of everting the uterus out of the abdomen, which I think, is a very noxious stimuli. And my resident and I were sitting there trying to have a nice conversation about, what is pain? Why do people have different pain perceptions? Was sort of one of those philosophical talks. And then he said, I'm not really sure I believe this machine, because there's just no way that this lady is having an open hysterectomy and it's been 3 hours and we've given her basically 100 of fentanyl, of opioid, and the gabapentin and the acetaminophen. And I said, let's trust the machine, let's do what it says, let's follow the protocol. And if she wakes up and is screaming in pain, we'll throw the machine away and send it back to Nacho. And so we followed the protocol and did not give the patient any additional opioids. And she woke up in the PACU and was just as happy as could be. And it really hit me then, because I thought, if I didn't have this machine during this case, I for sure would have given her more fentanyl, because I would say on average for these sort of open cases that my colleagues and I do, if you pull our data, we're probably averaging about 250 mics of fentanyl. And, you know, I think in terms of opioids, like Dr. Varghese talked about earlier, you want to give the minimum amount necessary to prevent pain and the inflammatory cascade that follows those sort of inflammatory mediators. But of course, we don't want to overshoot either. And at best, in some circumstances, we are giving our best educated guess. And in this woman, I think I probably would have given her more fentanyl and it would have been too much for her. She may have had a, slow emergence or some respiratory compromise in the PACU. I mean, I'm not really sure. But I really appreciated that the machine kind of helped me manage her intraoperative case here. So just some take-home points. We have so much technology on our hands these days. And when I first got this machine and I tested it out on on a few patients, I thought, it's pretty cool. Like, that's nice. But the more I used it, the more I began to rely on it. And then you sort of, at first I was only using it for my research cases, but then when I was doing my normal, not research cases, I was sort of longing for my ANI, and that I think speaks to the usefulness of the monitor, that I actually wanted to use it for my regular clinical care. And then in my institution, we haven't really moved to this opioid-free technique where, it's no opioid at all and you're running several infusions. We do try to be opioid sparing and maximize our use of regional anesthesia whenever possible. But I do want to mention that the HFVI monitor can be used during opioid-free anesthesia when you're running infusions of dexmedetomidine, lidocaine, magnesium, all of these multimodal sort of recipes that Dr. Mollier and his colleagues have sort of pioneered. And then hemodynamics do not always reflect the surgical stress of the patient, right? We use that sort of as a surrogate marker, but it really doesn't tell us about what is happening, on the inflammatory cascade and pain otherwise. And then, like I said, what we do, without the ANI works most of the time. Sometimes we undershoot a little, sometimes we overshoot a little, but I think we can always do better. And I really like this machine because I first started using it for research, and now I want to use it for all of my normal cases because I really feel like it allows me to titrate my intraoperative analgesia much, much better, and to tell if a block is working. I can tell the pain team, like, oh yeah, your block is good because, this guy's riding high the whole time, or, new resident on the rotation and, patient's not doing so good with their AV fistula under a MAC. And I can tell, like your block is not working. So future directions, multimodal approaches, I think that's where we are moving with anesthesia as the pendulum swings in life. We are swinging away from opioids and more toward non-opioid adjuncts. Many surgical subspecialties have created ERAS protocols designed to prehabilitate patients before they come into the hospital to sort of get them in tip-top shape, and then do everything we can in a multidisciplinary approach to take the best care of that patient and have them get home as quick as they can. And all of this sort of matches into that very well. As you all know, and as Dr. Varghese mentioned, we have an opioid epidemic in the United States. We have, 500,000 people who have died from overdosing. And we have patients who come in on large doses of opioids. And we sort of, during the case, we don't really know where we are in terms of their analgesic state, right? Because they're so tolerant. And then we give other adjuncts like dexmedetomidine, lidocaine, and then with the ANI, we can sort of see where we are. And then another interesting thought I had not too long ago was that when I was in the COVID unit taking care of a patient, you know, they're so isolated. We don't check on them like we do with normal ICU patients. They're just sort of on a ventilator, and we sort of, you know, adjust the ventilator settings from outside the room, and they're just sort of locked away in that box. And I wonder, you know, if we could apply the ANI technology to make sure that these patients are truly comfortable while they are being treated for their COVID. So those are just some future directions that I had thought of. And I will turn it back to Nacho.
So thank you very much to all of you. I think it has been a very, very interesting presentation. Now I am going to open the question and answer mode so the audience could make their own questions. Well, I've just got one here, which is, I will read it for you. It says, do you see any benefit using HFVI in outpatient surgery? I don't know if any of you could answer.
I can speak to that a little bit because we're just starting to do, I work occasionally in our ambulatory center, and they're starting to do same-day spine surgery with a very elaborate ERAS protocol. The patients are not supposed to be complicated, but they very often are on pretty significant amount of opioids for a one-level discectomy. And we're planning on using it for these patients, mostly to confirm that our ERAS protocol is going to work for these particular patients. But yes, the plan is to get them comfortable enough to go home for that day. And I think it could be, it depends on, I guess, the duration of the case and if there's going to be pain that you're concerned about.
Any other comments from you, Tiffany or Sergio?
No, I think it could be used in the ambulatory setting because, you know, we are pushing the ambulatory envelope every day. Cases that 5 years ago would not have been ambulatory, we are doing now. A lot of, you know, morbidly obese patients, patients that are, you know, ASA 2.5, 2 1/3 kind of patients. And I think the ANI is helpful in those patients because it just allows us to titrate our analgesia better so that we don't, you know, overshoot.
Mm-hmm. Yeah, I might add as well that there has been recently a publication made in, I think it was in the Clinical Journal of Monitoring and Computing, which was just an observational study in saphenectomies. And the doctors conclude that it was just an observational study. I mean, they were just gathering patients, and later on they look at the values of the ANI monitor and the time that the patients were discharged, right, from the unit. And they showed that those patients who had a higher percentage of ENI during the surgery, over 60, they had a lower time in the post-op unit than those who had a lower ENI. So it means that, you know, I mean, you were treating the patients, and obviously some of them hemodynamically guided, I mean, because the ENI was blinded, right? And they showed that those in which by lack or by whatever reason they were having higher ENI values, they had 11% less time in the PACU than the other ones. So this is an interesting data as well, although it's just an observational study. Obviously, it's not a randomized controlled trial with all the problems that it may have. I have another question here. Can the ENI electrodes be applied on the back of the patient to accommodate chest procedures? Any of you have any experience?
I haven't tried it yet.
I tried it for a thymectomy, and it did not work very well. The signals were bad, and I don't know, it didn't work very well for me.
Mm-hmm. I might say that
Nacho may know this.
Yeah, I tried several times, especially Tiffany, you were talking about a case that you had, right, with an sternotomy, and obviously you cannot place the sensors where normally say. So what I do is I put them on the shoulders, and I especially look for a bone, because the bones are the ones that are really transmitting better the signal. So as long as you get an ECG, wherever you put the sensor, that might be good. I mean, in children, or in very small persons, or elderly people, even I get some signal just putting on the on here on the wrist even, but this is very unlikely. Normally I just use the shoulders, which normally it works more or less okay. I have another question. Is there a benefit for the monitor go with the patient to pack you? So I mean that he's asking about the use of ENI or HFVI in awake patients. Do you have an experience on that?
I have been tempted to do this when I'm covering PACU and you get called to see with someone. They're saying, I'm in pain, I'm in pain, I'm in pain. I've been dying to put it on and see if it's validating, but I don't think it's going to be very good because you have to have a very regular respiratory pattern. Two, honestly, I have used it for several sedation cases, and if the patient is on dexmedetomidine and they're breathing at a regular respiratory rate, you will see any particular changes, particularly when they're going to do something very, very painful. We do a glycerol injection for trigeminal neuralgia. And I was able to demonstrate it intraoperatively. Yes, it was very, very painful. The surgeon didn't think it was painful, but the patient certainly was complaining, and we could see the response before she, jumped off the table and pulled it out of her her face. So
Yeah.
I don't know yet if it's going to be useful for PACU. And once again, I think it's really the way that the information is generated. But maybe if you had a very calm person, I don't know, maybe in your pre-op experience, Tiffany, do you see the people who give you a heads up that they're more reactive, their sympathetic tone is greater than their parasympathetic?
Yeah, I mean, we put it on pre-op. So different, it is kind of interesting to see some people, start at 40 and some people start at 80. And I did a few cases where I took the ANI on the patient to the PACU, which is sort of cumbersome because it's sort of a big monitor and we're holding it, and it doesn't help for awake patients in the PACU, because even when the patient is hurting and they're asking for pain medicines, and then you point to the ANI and you say, but sir, your ANI is 70. Like it doesn't help. Like they still say that they hurt. So you can't really, it doesn't do anything.
Hence the difference between pain and nociception, right?
I think that pain is a much complex concept, and it may have a lot of different other factors that may interfere on that. I just may tell you something that it happens here in Hospital San Sebastián de los Reyes in Madrid. That was a lady who was going to have, she had a breast cancer. So she was going to have a mastectomy, a radical mastectomy. So we went into the OR, we were managing the ENI and the remifentanil and propofol. It was done with TCI. Everything was perfect. So the patient went into the PACU and I waked her, and she started crying. She saying that she was painful, etc. And as you said, Tiffany, the ENI was on 70. So you were saying,
yeah,
come on, you don't have pain, all right? You cannot do that. So but then the doctor went for getting some medicine, some pain medicine for the patient, and I was just there and started to talk with her. And she said, well, I said, what's going on? I said, well, I just went through a mastectomy and I have a lot of pain here. And I said, well, you know what happened? The surgeon, in fact, didn't do a mastectomy, but just an endolectomy because it was not needed, the mastectomy. So he said, no, but you've got your breast because it was just a noddle. And she just get the sheets, look at his breast. He realized that he had his breast, and the pain stopped completely. So I wouldn't never say that that patient was not suffering pain. She was really suffering pain, but it was not exactly what we mean, right? So yeah, I agree. I mean, the control might be the patient when the patient is awake, obviously, because pain is something more than just nociception, right?
Yep.
So I think I have another one like here. It seems that most everyone agrees that there's some connection with using high dose of opioids during surgery to increase. Sorry, I'm gonna move the screen. In post-op pain and chronic pain, but anesthesia may not see this as the patient is not a long-term patient for the anesthesia provider. Is it the surgeon that needs to be convinced?
Good question.
Yeah, I think I think it's a balance. So what we know is that if you have acute pain and you don't treat acute pain, you have more chronic pain. So that's an early observation, and it got to be taken very serious in some cases, like breast surgery, thoracotomy, cardiothoracic surgery is up to 50%. So that's observation number one. Now we are learning, as I point in my lecture, that maybe that the opioids may modulate in a negative way these pathways and may increase pain. Again, hyperalgesia, I think, is being proved more or less consistently. Acute pain, there are a few papers in there. In chronic pain, there's very, very little, mostly animal data. Most of the chronic data is more related to recovery and chronic opioid use, but that may be related to other things like prescription patterns. God knows why people would use opioids. So again, I think the first message that I want to make very, very clear is that acute pain should be treated very well, and that opioids still having a role in the treatment of acute pain, because that's going to minimize chronic pain. And the second part is that it just we probably have emerging data on minimizing the utilization of opioids because may have a negative impact.
Mm-hmm. Yeah, for sure. I got another question here from the other side of the ocean. Subjective against objective expression of pain, which do we treat? It's a little bit philosophical, I guess.
Both. Pain is pain. So I think in your example, very clear is we feel pain differently, and it's the fourth vital sign, right? So we need to treat it. We need to be very sensitive to what people feel. Now that doesn't mean that we cannot optimize treatment, and that doesn't mean there are other alternatives than opioids. But pain should be treated.
Yeah, sure. Okay, thank you very much. I think that we already arrived to our 1 hour and a half webinar. I want to thank to all the attendees to be listening to these very interesting new ideas, which is basically pioneers. You, Sergio, Irene, and Tiffany, you are really pioneers that are helping us to advance and to get further in these ideas of anesthesia, pain, nociception, etc. So hope you have a very good evening, and thank you very much for participating in this webinar with us. Thank you.
Thank you for having us.
Bye.
Bye.
Bye.